Hello, I'm Dr. Deirdre Frum-Vassallo, clinical psychologist at the Northport VA Medical Center. I do a lot of training in MI for the VA, and I'm a member of MINT. Today, I'm going to talk about ambivalence, and this is the first of two talks that look at different facets of ambivalence during this training. And so for this portion, we're going to look at this discord and distress, sort of that tension in a relationship that can come when there is ambivalence, and how to attend to that by using the MI core skills, otherwise known as OARs, and the spirit of MI. So this is the overview of the course thus far. And what's highlighted is where we're going now, which is the first of two facets of ambivalence, and looking at the use of the core skills and the spirit. Okay. So what you see here, this man looking at two doors and he's not sure which one to go through, it sort of summarizes that sense of ambivalence. If we were to try to encourage him to go into one particular door, perhaps the one on the right, what most likely is going to happen is he will actually go through the door on the left. So with an ambivalent person, if we argue for one side, they're more likely to defend the other. And so this is important to realize, this human nature when we're trying to work skillfully with ambivalence. So as a person defends the status quo, their likelihood of making a change actually decreases. So if there were something healthier behind the door on the right versus the door on the left, we might have some desire for him to actually go through the door on the right. And we realize that our first instinct to tell him to go through that door may actually decrease the likelihood of that. So the first thing that we want to kind of remember about working with somebody who is ambivalent is resisting what we call the righting reflex. So this desire to help, to encourage them to do the correct thing actually gets in our way. And so some of this may sound familiar to many of you in the audience, being clinicians for a long time. A lot of what we're going to talk about today may not be new, or may be slightly a different angle on things that you kind of already know. So encouraging you just to kind of keep an open mind as we proceed. So instead of this focus on fixing, we want to first focus on building a relationship with the patient, with the client. We want to engage them, right, that relationship, and then we can work on hearing their reasons for making a particular change, or what we call change talk. And this is what actually makes change more likely. We know it's time for MI, for motivational work, if there is ambivalence. If the patient knows what they want to do and it's the same thing that the clinician agrees upon, and there's no friction or resistance or sort of discord, as we call it, there's no need to be engaging these skills of MI. If there's ambivalence, that's the signal. It's time to back up and look at these skills of motivational interviewing. So this talk is going to focus on this piece, on ambivalence related to the patient distress or discord in the relationship between the patient and the physician or the clinician. So we'll first look at what we call the spirit of MI, also known kind of as the mindset, values, and attitudes behind using motivational interviewing. So if we think of MI as a song, the skills we use, OARs, are the lyrics of this song, whereas the background music would be the spirit. This Venn diagram over here breaks the spirit into its components, and we're looking at partnership, our ability to have the relationship with the patient be a true partnership, the use of a compassionate backdrop, accepting the person fully as they are and sort of resisting the tendency to be burnt out on patients who have difficulty changing, and the spirit of pulling from the patient what is important to them, or evocation. And again, this spirit may already be something that you employ in part or even fully in your own clinical style, and in the skills that you already have in your practice. And MI pulls upon these clinical skills strategically. So it may be something that really fits with you, or there may be things that you slightly see that are slightly different. So as we move along, just making note for yourself what actually fits with your current style and what you want to keep doing, and what might be a helpful change to employ. So looking a little more closely at aspects of the spirit, we'll look at acceptance, right? So when we talk about acceptance, we're looking at this resisting the burnout. So I call that the absolute worth of the patient. So when we tend to feel like this person will never change, we feel that friction, we're not in a place of looking at absolute worth. We might be feeling pretty burnt out on somebody who's very complicated, which is okay, but reminding ourselves about absolute worth reminds us to say to ourselves, okay, well, can this glass be just a quarter full? The patient showed up for his appointment or her appointment. The patient's here. That's something. So we really look for this desire, this seed for the person that wants to actually improve in some sort of way, and try to remind ourselves of that everybody has this absolute worth. We look to affirm. And so we'll talk about in our ORS skill how affirmation is a little bit different in MI. Through affirmation, we're looking to orient the patient to his or her own strengths so that we can empower them to make a change. So we're looking for things that are already there and helping them to build upon it. We also want to respect the autonomy of the patient, that it's their decision whether or not they even want to make the change. And they may very well decide that they don't want to do things the way that we recommend. And so we want to respect that ultimately. We can do beautiful MI and it's still their decision in the end. We hope that we can guide them towards making a healthy change, and yet we need to respect their true decision. And that's that piece of autonomy and really accepting where they are at. And accurate empathy, which is a little bit different than what we would think of when we just think of empathy, in that inaccurate empathy, we are using the conversation to make sure that we understand where the patient is really coming from. And so when we get to our ORs, we'll be talking about ways of reflecting back what's been said so that we're really testing our knowledge and our understanding, and the patient can help correct us as to whether or not we really understand where they're coming from. And so all these components come together to make up acceptance, being able to really sit with the patient where they are at. And this piece is particularly important with patients who we find that tension with, resistance, discord, stuckness. We really tune to this aspect of the spirit to help us be with the person as we move through that and create a space where movement is possible instead of a patient digging down even harder. Right? So accurate empathy, as I mentioned, it's really being actively interested and attempting to understand the other person's internal perspective, seeing the world through their eyes. It's different than having sympathy for somebody. And it's different from identifying with them and feeling like, you know, they're similar to us in some way, or trying to really feel that we're the same as them in some way. We are not imposing our perspective on the patient. We're really deeply listening. And so a lot of times when we're using MI, the patient is doing more of the talking than the clinician, and we're really listening. So now we'll talk a little bit about partnership, which is also part of the spirit. This is very different than authority. It's really contrasting with us as the expert and the patient as needing to listen to our expertise. We're really honoring the patient, the person, as the expert on their own life. And so we do have expertise. We do have things that we've learned over the years. And MI is helping us to really skillfully kind of join this expertise that we have, our professional expertise, with the patient's expertise on him or herself. So it's this partnership, this coming together of knowledge and really respecting what each other bring to the table. So we're honoring the client's expertise and perspective. We're providing an atmosphere that is conducive rather than coercive to change. And again, the therapist is doing less than half the talking. So this real opportunity for listening. Supporting autonomy. We're respecting the fundamental right of the patient to change or not to change. So now we're going to turn from the spirit to talk a little bit more about these lyrics, ors, or the skills, right? So these are the foundational skills of MI. We call them ors because it stands for, it's a mnemonic for open-ended questions, affirmations, reflections, and summaries. And here in this picture, you see the metaphor of oars, which is that we are actually using oars to move in the direction of change. Like these actual oars on this boat would be in the water, moving towards a target. We're actually using our utterances and our language to help move the client towards a target. So that's a good way to remember oars. Open-ended questions, affirmations, reflections, and summaries. So here, this picture is a metaphor for levels of reflection. When we look at this picture, I'll ask you to think about it as if it were a metaphor for a conversation that you're having with a client or a patient. In the picture, take a look and see what you notice. We have a body of water. We have things that are showing up in the frame that are actually from outside the frame. So things that are reflected into the water. We have items that are floating on the surface of the water. And two, underneath the water's surface, we can see evidence of something underneath the water's surface, right? So here we see a koi fish under the surface of the water. So when we talk about the levels of reflection, sometimes in a conversation, we use reflection to bring into the frame something that's occurring outside the frame. So like these trees that are actually not a part of this picture, but actually occurring outside the frame of this picture, a conversation might have evidence of some other context that we might use our reflections to bring in. Or perhaps we're simply repeating back to the patient things that we heard them say for that accurate empathy, for that ability to really let them know we heard them. Those are like the leaves on the surface of the water. The patient says, "I'm not feeling well." And you repeat back, "It sounds like you're really not feeling well." Or perhaps we feel that there's something sort of beneath the surface, perhaps some body language, facial expressions that lets us know that the patient is feeling something. That's like this koi fish under the surface of the water. Yeah, it seems like that really doesn't sit well with you, right? That's an example of a reflection that would go beneath the water. So these levels of reflection, as we talked about, the leaves, right? That's like this simple reflection that repeats or restates what was said. Or we have complex reflection, which is adding some meaning or emphasis to what the person has said, or guesses at the unspoken. So bringing those trees into the frame, looking at those koi fish or other things lurking beneath the surface and adding some complexity. A double-sided reflection is an example of a complex reflection that actually acknowledges ambivalence. So it is talking about both sides of ambivalence, but we're very careful to end on the side of change. So for example, if we had a patient that was thinking about quitting smoking and they were telling us how much they turn to smoking when they're stressed out as a coping mechanism, and yet they've been diagnosed with COPD, which really worries them, we might say something to them such as, it sounds like smoking has been your go-to coping for when you're really anxious. And yet you're really concerned about your diagnosis of COPD. So by ending on the side of change, we then invoke the recency effect. So research shows the last thing we say, most likely the person is going to pick up on that and keep talking about that. And so if we end by mentioning the patient's concern about COPD, we're hoping, and most likely they will, start to talk about that concern for COPD, which is change talk, which is reasons, desires, needs for wanting to move away from quitting smoking. Another type of reflection, a complex reflection technique, which is really important when we're working with somebody who's ambivalent and when we're feeling that tension in the relationship, is called coming alongside. And coming alongside is one of the only times in MI when we actually reflect the status quo. We reflect that stuckness. If a patient is showing a lot of discord or resistance and we just feel that tension, we just come alongside them. And we might say something like, you're really feeling stuck about this right now. Simply reflecting where the patient is at. Now let's talk a little bit about affirmation. As I mentioned before, it's a special type of reflection that emphasizes a strength. We are trying to build the patient's self-efficacy and orient them to their own internal resources. These statements must be personal and genuine. So it's not about what you think, what I think, but something that we see in the patient. It's really shining this light on something positive in the client and not about our evaluation of the client. Therefore, these are often you statements, not I statements. You really show that you have tenacity by coming week after week to these appointments, not I believe you have tenacity.